Well, hello. My name is Nilofer Azad, and I am a medical oncologist here at Johns Hopkins University at the Sidney Kimmel Comprehensive Cancer Center. I have been focused on taking care of patients with colorectal cancer for the last 15 years, and I'm very happy to be here today with Cancer Nursing Today as a roundtable to focus on colorectal cancer with two of my colleagues, Rachel Klein, who's a nurse practitioner who works at Johns Hopkins as well, and Fatemeh Youssefi, who is also here representing nursing that takes care of colorectal cancer. Would you like to introduce yourselves, Rachel and Fatemeh?
Sure. Thank you so much for having us. I'm Rachel Klein. As Dr. Azad said, I'm a nurse practitioner at Johns Hopkins University in Baltimore, Maryland. I take care of gastrointestinal cancers, primarily colorectal, alongside Dr. Azad and our other colleagues. And we also participate significantly in the development of new therapeutics, and a lot of our patients are participating in clinical trials, such as the ones we may be discussing today.
Hi, my name is Fatemeh Youssefi. I've been a nurse for many years. I'm participating in this program as a registered nurse, as someone that's taking care of the colorectal patients through the spectrum of their life, expanding infusion and making sure that the quality of life is being met, and talk to our colorectal patients all the time about how they're looking at their goals and measuring their goals for their lifetime. And thank you for having me on this program.
Thank you so much for joining us. So how we're going to structure our conversation today is to talk about a few different important areas in terms of how we take care of patients with metastatic colorectal cancer. And we really want to focus today on metastatic disease. There are a lot of nuances to taking care of different stages of colorectal cancer, but today we're going to really focus on some of the challenges and opportunities that have come up in terms of taking care of patients with more advanced disease. And so I'm just going to start with a little bit of background about metastatic colorectal cancer. As many of you know, colorectal cancer is the second leading cancer killer in the United States. It has been a cancer where the mortality has been slowly decreasing, mostly because of improved screening over the course of the last decade. But unfortunately, 20% of patients are still diagnosed with metastatic disease, and metastatic disease is generally considered incurable for the vast majority of patients. Though, of course, there are a small number of patients with metastatic disease that we can still treat with curative intent. And so what I'd like to start with is to talk a little bit about how you approach a patient who comes into the clinic with a new diagnosis of metastatic disease. So Rachel, you've been involved in taking care of a lot of patients and seeing them from the very beginning of their cancer journey. Can you speak a little bit to how we talk to patients with their first diagnosis and what things we're thinking about when we're making some choices?
Mm-hmm. Yeah, it's a great question. I think with anyone who's coming in with presumed or confirmed metastatic colorectal cancer, I think the first thing is really to ensure that the staging has been completed. Sometimes patients are coming in without a complete set of testing that would confirm whether it's biopsies or different modalities of testing, to just really understand the extent of what we're dealing with, and also the specific molecular diagnostics that would be pertinent to how we would treat them. And once we have that information, and I'm sure we'll expand on that a little bit more, but I think that setting expectations to the best of our ability is a really important concept from the onset. Striking that balance between optimism and also realism can be a challenge. And, even for us as experienced practitioners, we can't always tell someone their true prognosis right away. Oftentimes we're honest with patients that we won't actually know how long they can survive with this. I mean, it might be, years if we're able to, treat them effectively for a prolonged period of time with systemic therapies or localized therapies in conjunction, or even surgery down the line. But it may be unfortunately a shorter time frame, but it really depends on how they respond to therapy. So again, trying to just express our optimism that we're part of their team no matter what, express that we care about them, we care about their lives and their goals within their lives, because we don't want them to miss important events, and we want them to focus on what is truly aligned with their values in their life, alongside treating this cancer as hopefully a chronic disease for as long as medicine will allow.
Yeah, I mean, I think you brought up a lot of really important points about that first visit that I'd love to talk about just a little bit more. So the first thing you mentioned was molecular testing, and this is a cancer where a patient's molecular testing really guides first-line therapy. And so what the most important things that we need to know for a patient is, number one, do they have microsatellite instability? That is a test that's done on their pathology specimen. And if a patient has microsatellite instability, which is only present in about 5% of patients that have advanced disease, their first line therapy is actually going to be immunotherapy. And I think we can talk a little bit. I really hope we're going to be able to flesh out side effects of some of these, especially with you, Fatemeh. So I think that's an important consideration because it's a different side effect profile, where immunotherapy is very effective for those patients. And they may have a genetic syndrome, and that's an important thing that as a care team between nursing, physicians, we need to make sure to remind ourselves of, that any patient who's on immunotherapy for colon cancer needs to also undergo genetic testing. That's one test. And then the other group of tests is looking for KRAS and BRAF and NRAS mutations. Those mutations, if patients have them, means that they should not get an EGFR inhibitor in their first line of therapy. And so that's another key piece of information that we need to know. And the third part of making the decision is around whether or not their cancer is left versus right-sided disease. So patients with left-sided colon cancer that don't have a mutation in any of these genes like KRAS, NRAS, BRAF, they can get treatment with chemotherapy plus an EGFR inhibitor. But if they have right-sided disease, they also don't get an EGFR inhibitor. And one of the things that is particularly interesting to me is that when we have a patient with left-sided disease and we say, okay, you have an option between getting the EGFR inhibitor therapy or not, sometimes patients will choose to not do EGFR inhibitor therapy. And so maybe, Fatemeh, could you talk a little bit about that side effect profile that patients experience on chemotherapy with colon cancer? One, if they get the EGFR inhibitor therapy, and if they don't, just because it's such an important part of the conversation as patients are making up their mind.
Sure. I think right at back for the patients to understand the disease process, right? And we talk about health literacy. We talk about understanding those terminology. What does that mean to have a right side versus left side? As a nurses, some of our roles is to kind of reinforce what the providers have talked to the patients about it and the options that they have, as well as reinforcing the adverse effect or side effect that these patients may experience. We know and I'm just going to use a regimen such as FOLFOX, the long-term impact of the patients have a chronic neuropathy. How is that they're going to impact their life? And also, we talk about the mouth sores. We talk about the fact that these patients have to come for the disconnect of the pump and go home on a pump. All those lifestyle changes that's involved, it's extremely important when someone's make a decision to stay on a chemotherapy. And when we talk about EGFR receptors or such as things that if they have any underlying, have they been disclosed all their medical history to the patient, to the providers, because it's so funny how about in infusion, the patients open up to nurses and they're amazing that how much they share some of other medical comorbidity or anything they may have that they fail to share that with the physician. So as a nurse, it's kind of transition that. When we talk about the fact that they may have some high blood pressure when they come for the treatment or passing the protein in the urine, basically, Or when we're talking about the immunotherapy, we know as the immunotherapy has its own set of the side effect, and how would the providers would choose to treat those side effects. At one point, they continue the treatment, where such as when we talk about the rash and diarrhea, and what point is the immunotherapy causing the diarrhea versus actually the disease. So it just open dialogue and encourage the patients to report their symptoms to the providers. So, and as Rachel said, meet them at the goal that they're at and the expectation, the realistic. We don't, as a registered nurses, we don't go on as a talking about the prolonged survivals and all those, but we definitely kind of help the patients to make a decision for themselves, open up the information, providing them accurate information to make the right decision for themselves.
And I think that's a really important point that you brought up and that Rachel mentioned as well, is that it's very important for patients to know, and for us that are taking care of patients to know, that when a person is diagnosed with metastatic colorectal cancer, their average life expectancy at the time of diagnosis is 3 years. So they are going to be, and they tend to actually do well in terms of quality of life and performance status for most of those 3 years. So I think that's probably a very important consideration as part of a care team, and especially for the nursing that are taking care of them, in terms of how you talk with them and are realistic with them, compared to some of our other cancers that, you know, are more difficult and who and that may not have that same life expectancy. So I think that's a really important point that you bring up.